Welcome back, everyone, to MorningLine. Thanks for joining us. It's a good show. Our guest with us this morning to talk about how to be safe in the sun is Dr. Bill Stebbins. He's a dermatologist over at Vanderbilt. Nice to have you on. And
Thank you.
He says he spends much of his day performing surgeries, correct? These are, just so you know, the types of surgeries that oftentimes, if you caught early, are pretty routine, aren't they?
They are. And the key is catching them early. And the earlier you catch them, the easier it is to treat them.
Just boom, take it off. It's outpatient most of the time.
It's pretty much 100% outpatient, which is great.
Do you guys, is it just you numb the area and remove the section of skin that needs, or is it frozen off, or can you do it other ways?
So what we do is, I do something called Mohs surgery, which is M-O-H-S. A lot of patients come in and say, I'm here for my mole surgery, and it's named after Frederick Mohs, who invented this technique about 50 years ago. And it's a technique where it allows you to remove a very, very small margin around a tumor, and then we bring that to our lab where our histotechnicians freeze that specimen instantly, and about 20 minutes later we have slides we can look at. And the way that we take the piece, we can actually look at the entirety of the margin, so the whole outer edge and underneath it, and we see if we got it all. And if we don't get it all that time, we'll know exactly where on a map, almost like a clock face. We can say, oh, there's still some tumor at 2 o'clock and a little bit at 3 o'clock, and we go back to the patient, 20 or 30 minutes later, and take just a little bit in that area. We reassess that.
You want to get it all.
And we keep going until we get it all.
Yep.
And so it does two things. Number one, it preserves tissue, so it only takes what you need to, and it is by far the most accurate way to remove skin cancer. There's nothing better than that.
It's the way to go.
And then you can reconstruct them that day. Now, take that in contrast to going to a surgeon who might just say, well, let's do an excision. You have a basal cell here. I'm going to go to a plastic surgeon. We'll take it off with 4mm margins. And again, not due to their own fault at all. It's just the nature of these tumors. They can be very subtle. They may remove that tumor with a 4mm margin, which may be too much or too little, right? Because we only start with about 1 millimeter or 2.
Yeah, and you are checking with the Mohs. Yeah.
And so what happens is that tissue gets removed, sent to the lab. They stitch the patient up. 3 days later, they get the report back, and they say, oh, there was still some tumor in there. And so, again, it is not, we work with our plastic surgeons all the time, and they are unbelievable. It's just that this particular technique, we share patients with them all the time where they might refer for us to remove them, and we'll send them back to them to reconstruct. And we do the majority of our own reconstructions, but when we do get referrals from them, we share them with them, and our Vanderbilt plastic surgeons are fantastic.
Wow. Yeah. Okay, let's go next to Mike. Mike, good morning.
Good morning, Nick.
Hey, Mike, what's on your mind?
Hey, my friend. Hey, I'm the guy that's really been kind of nothing about against the guy you have on your show. My question is, I hate to ask, but because I'm off from work today, and I've been talking to you about the homeless situation, and my question to you, Dick, if you don't mind, is there any way somebody from my church could maybe email you? We'd like to invite you out to a dinner that we're having.
Well, what I'll do is put you on hold, and Rick can get that number from you, and we'll see if we can work that out. He's called before. Yeah, just stay on hold on line 2. Let's go to Ruby. Ruby, go ahead.
Yes, how y'all this morning?
Good, Ruby. What's on your mind?
Well, I got a place on my eye.
On your eye?
Yes, right under, on my cheek.
Okay.
And it's been, it ain't too big, but I can wash and it'll bleed. And I'll put my finger on it and, make it soft and put a press on it. And I just wondered what that could be.
Have you ever had a doctor look at it, or a dermatologist?
Oh, it hadn't been up there about a month.
So it's only been there a short time. All right.
So that sounds like a perfect time to get in and see a dermatologist.
Yeah.
And again, Ruby, you're describing exactly what we look for, which is a changing spot that's either growing or bleeding, and repeatedly bleeding even with light pressure or rubbing. So that's something that you should get in touch with either your primary care doctor or a dermatologist to take a look at that and maybe take a sample of that to see.
Yeah, so give people an example of someone like Ruby who makes an appointment to go to a dermatologist, and a lot of insurance companies will cover it. Even if you have a deductible, an office visit's not a fortune. You go in, essentially you are going to have a physical exam. You walk people through what they do when they come in, and how you just basically look at them.
So we have patients come in and undress usually to their underwear.
Yeah.
And we take a look from head to toe, and usually it's a very consistent exam where we sort of start in the scalp and we work our way down, and we certainly address any questions they have as well.
Because maybe they'll point you to a spot.
Exactly,
right?
and oftentimes they'll come in with a complaint, like Ruby might have come in and said, what's this? And we'll say, well, if you have that, you might have other spots as well. Let's just take a look head to toe. And once we establish a baseline with them, it may focus our exam in the future in different ways. But in her case, what we would do is we'd put a little drop of numbing in this spot, and we'd take a thin piece, and we'd send that off to our lab to have that evaluated. And again, that's one where we would send off to our dermatopathologists, who would read it over the following day or two, and then give us a report with what they found. And so it's a very, very quick, simple procedure. There's no downtime at all. Oftentimes there's no stitches, almost uniformly there's no stitches with a little sample like that. And you just have a little Band-Aid on there, and it's super easy.
Ruby, I've had it done several times. I've had 3 or 4 taken off. In fact, last year I had at least 3 off. And more often than not, the lab result comes back, and you're right, there was no stitches, maybe a little blood when they do the bandage, but it came out that what they looked at was possibly a pre-basal cell condition or something like that. It hadn't become that, but because we caught it and removed it, it never became anything. And after they did that, there was no other follow-up. I mean, the test came back. She said, look, we took it off. It turns out that it was not full-blown yet. Right?
Exactly.
And that's it.
A lot of times what you're describing sounds like what we'd call a precancer or an actinic keratosis.
Yeah, that's it.
Yeah.
That's it.
And these are scaly spots that show up.
I love having scaly spots. That's awesome.
Yeah.
That's awesome.
They're almost invisible. They're more, like you can palpate them and you can say there's something just rough and scaly.
Sure.
And so for men shaving, they might be able to shave it off every day and not necessarily notice it, but you'll feel a spot that keeps rescaling and falling off, rescaling. And that's usually precancer, and oftentimes those are either treated just with a light freeze or sometimes just a topical cream that we'd use for an amount of time to get rid of those. So there's a lot of different ways to treat those. And
I guess they're fairly common. And I don't know if this is what my friend, I forget what he said, but I was at the gym the other day working out, and a friend of mine walks in, an older gentleman, and he was covered, his head, with little Band-Aids here, and what the heck happened to you? And he goes, I just came from my dermatologist, and I forget what he had, but he has these dry spots that are precancerous or something, where they went on one day and must have removed a dozen. Is that what we're referring to there, or?
Yes, and oftentimes, again, if we clinically see those as precancers, we don't usually biopsy them. Unless there's a concern that it's been treated once or twice and still come back. But usually, when you treat them by freezing them, you usually get them. The large majority of the time, just by doing that, or by using again a topical cream that can be used, with different intervals and over the course of a few weeks to help improve that. And again, the new ones will come. Once you have those, usually it's like weeds in the lawn. New ones will appear next year, and so you do need to stay on top of it. But it's usually something that's very manageable.
Yeah, it came back. He just was a gardener, and it came out. All right, let's talk, if we can, a little bit about sunscreens then. Originally the first ones were like 15, and now I've seen some, I think, up to 60. What do you recommend? And should it be a lotion you rub on? The convenience for me is the spray. What do you think?
I agree with you that I personally love the spray, and I think so. First and foremost, it's whatever works best that a person's going to use, right?
Yeah,
so, because if you give a man a thick, 100 SPF cream to use, and you try to put that on your arms, it's going to be a real pain in the neck, right?
Yeah.
You're not going to be able to rub it in, and so. Number one, for sort of baseline when you leave the house every day, because you're getting sun exposure when you're driving in your car, right? UVA gets through those windows.
That's worth saying, by the way. A window is not going to keep the sun out.
Correct.
I mean, the damaging rays.
Correct. And so, a lot of times I wear 30 every day just leaving the house.
Okay.
And that's just in my moisturizer, and there's a million moisturizers out there. They're very inexpensive and work great. If I'm going to be outdoors, let's say I'm playing a sport or going to be outside doing whatever, I'll have at least 50 on, but my real go-to is the 70 spray.
70 spray.
And the reason for that is, again, not that it's protecting you, right? So 15 is going to get 93% of UVB, 30 is going to get 97%. So the reason I'm using 70 is because, again, it does work a little better, but I actually prefer the sport version of it because it stays on longer, even with sweat, and I can spray it on my hand and rub it on my face without it getting all white and sort of, which gets bothersome.
Yeah, I do the same thing.
I can spray it on my neck without it getting everywhere, spray it on my arms and easily rub it in. And again, all those areas that you forget about that, as a guy especially, as women are far better at this than men, but protecting our ears. And in men, when you start to, if you have lighter colored hair, start losing your hair at all, that sun's getting through.
I was going to say, I mean, now, I'm not getting bald yet, but do I need to worry, or is the hair providing protection?
The
or should I wear a hat?
providing a small amount of protection.
Well, what do I do then? I mean, I'm out in the sun.
You gotta wear a hat. And
you
so
have to wear a hat.
When I'm outdoors, I play a lot of tennis. I'll have a hat on. I'll have sunglasses on.
Okay.
And I will have sunscreen on 30 minutes before I get out there.
Gosh.
And then I will reapply it probably an hour after I've been out there. And it is annoying because you're sweating, and but you know what? The alternate is much worse.
I know.
Right?
Sometimes you see the folks with the zinc oxide, that which is just whiter. I've seen they've made it in different colors. Now, is that 100% block? Is that what that is?
When it's really white like that, it's pretty close to 100%.
Why is that? That's just a cream. You've probably seen sometimes some guy with, playing tennis with...
or the sun, classically the lifeguards.
Yeah, lifeguards that are out so much have a slather of that on maybe the most worrisome spots on their body that get the most, the nose.
If, they've actually been able to micronize that zinc, so in other words, make it less white. And so a lot of the sunscreens out there today actually have that same zinc in it, but without it being white. And the way zinc works, there's organic and inorganic sunscreens. That's an inorganic sunscreen. So zinc and titanium are the two components that are most commonly used, and they just reflect the sunlight.
Okay,
So if you look in your sunscreens, a lot of the broad spectrum, which cover both UVA and UVB, will have one of those two in it.
That meaning it reflects it away as opposed to also just covering you.
Exactly.
Wow, that's
and
interesting.
So, the other sunscreens, the organic ones, actually chemically convert the ultraviolet light to a small amount of heat, which is kind of interesting. Yeah. And so that's how they work.
Technology beside something, but they're good and they're effective, which is great to know. All right, listen, on that note, let's take a break. Back with one more segment right after this. Stay with us.